Well, welcome to this talk. We're going to be talking to Dr. Tess Lawrie about ivermectin. And of course, you would never take any medication based on what we say on this channel. This is for academic educational interest. If you want to take some medication, go to your own doctor or prescriber and get them to prescribe it for you. So enjoy this educational discussion with Dr. Tess Lawrie. Right, welcome everyone. It is now the 5th of April. And we last talked to Dr. Tess Lawrie on the 5th of March, so coincidentally a full calendar month. Now, I'm delighted you've come back after I kept you for over an hour last time, Tess, so it's really kind of you to come back. We appreciate it. And I know lots of viewers have been looking forward to an update. Background here is you're a medical doctor. You've worked in obstetrics, gynecology in South Africa. You've got a lot of experience on the ground. But you're also a research doctor, so you're really Dr. Tess Lawrie. It sounds like you've got a good background for this. And for a while, you've been specialising in this research, and you're currently working with in fact, I think you're in charge of the evidence-based medicine. Is it consortium or
consultancy?
Consultancy, yeah. Evidence-based. It's my writing. I can't even read it. Evidence-based medicine consultancy, and you basically put together data. You make recommendations to the Cochrane, which has got major implications for UK policy. You make recommendations to the World Health Organization.
Yeah. Now, so we don't make recommendations. We provide the evidence for the recommendations to be made.
Right. So you provide the evidence, and then they can basically do what they want with it.
Yes.
Yeah. And you usually, up until some provisos at the moment, that's usually been fairly positive, I think.
Yes. Yeah. There's usually a correlation between there's a correlation between the evidence and the recommendation that gets made.
Well, one would hope so. Yes. The evidence is always good. But the background here is there's this drug called ivermectin, and it came out mid-70s, I think, was it?
Yes. Yeah.
And it's brilliant at treating parasites. It's been used for several billion doses of it have been given. The doses are known. It's on the World Health Organization list of essential drugs for its anti-parasitic properties, which are all well proven and well established. And it's been a major benefit to humankind, I think it's fair to say, as a result of its anti-parasitic properties. But then recently, antiviral properties have also been identified. And in vitro, it's clear that there are antiviral properties, and by continuation, when the current pandemic, which of course is caused by a virus, SARS coronavirus 2 RNA virus, that ivermectin also seemed to have antiviral properties against SARS coronavirus 2. Yes. And we looked at evidence from that last time. So there is in vitro and in vivo evidence for the efficacy of ivermectin against SARS coronavirus 2 from your studies, Tess. Is that basically?
Yes, yeah, and fascinatingly, it seems to have a number of mechanisms of action. So, there have been papers written, as early as, the 90s in terms of its various mechanisms of action. So there's much that can be studied going forwards as well, just to, look into how this amazing drug seems to work.
So antiviral properties of ivermectin have been known since the 1990s?
Well, not necessarily that, but different mechanisms of action. So there have been lots of papers showing many different mechanisms of action, which could all be in play now, given that with SARS we have inflammatory responses as well as virus load to deal with and viral proteins so it seems to have, and I'm sure more research will show as well, many different mechanisms of action, which makes it really useful because it means it's not strain specific and it's not a stage of the disease specific. It seems to work across all stages.
This is a big thing, of course, with COVID-19, isn't it? We have the viral stage at first. And then we have the inflammatory stage when the body, in most individuals, has been able to eliminate the virus. And of course, one of the main treatments now, the dexamethasone, which is the steroid anti-inflammatory, I think most people would consider that to be contraindicated in the viral stage of the illness, but of course can be absolutely life-saving, as data has clearly shown in the inflammatory stage. But the indication here is that ivermectin could potentially work in both stages of the illness.
Yes.
Excellent. Yeah. So up to when we talked on the 5th of March, Tess, can you give us just a brief review of where we left off there, the data you've been looking at, and the conclusions from that data?
Yes. So on the at that time we had done our systematic review, and we had included 21 trials, and 13 of the trials had contributed data to the meta-analysis on deaths. And we found 68% reduction in deaths. In fact, let me show you the slide. Can I share screens? And then
please, yeah.
Okay. So yeah, well, the first review that was done was Andrew Hill's review, and that was the 18th of January. And he found 6 randomized controlled trials to include in his analysis with 1,255 people. And it showed a clear reduction in deaths, 75% with ivermectin. And he also looked at viral clearance, and he found there was a clear reduction in viral clearance as well with ivermectin. This study review was funded by the World Health Organization and UNITAID. And the gist of it was that they were still waiting for more data, so they didn't want to make a decision on this evidence. Well, we did our review, and we found that very similar findings. We found a 68% reduction in deaths, but we included 13 studies in our analysis, and this is what I showed you last time. The risk ratio of 0.32 indicates a 68% reduction, and the effect lies clearly to the left of the line of no difference, which is clearly in favor of ivermectin. And the confidence. So
that up and down line there, Tess, that's yes. The line of no difference.
Yes, yeah. So if a study, so each of these lines represents one study. So study findings. So if you look at this data from the El Ghazar study, you can see if you look at just that study, well, the effect seems to lie to the left in favor of ivermectin, but it does touch the line and it crosses over, which means that in actual fact, it could be no different, or it could even lie somewhere over here, the true effect. So if the true effect lay over here, well, then it would favor the control group. So it's only when if you look at any one individual study, because these studies are not powered to assess a big difference in deaths, also in mild disease, for example, you would need thousands of people to establish a clear difference in deaths. You need to be able to pool data. So when you pool data from all these studies, you can see most of them lie to the left of the line, and then the overall summary is the overall effect estimate. And in this case, it's an average across these studies, which gives us a risk ratio of 0.32, corresponding to a 68% reduction in deaths, which is
this is the forest plot, Tess, is it?
Yes, it's called the forest plot. Now you can see from this number here, this I squared equals 57 and P equals 0.02. This suggests that there's a significant difference across these studies. There's a bit of inconsistency across the studies, and one would expect this because ivermectin is going to work differently in different severity of disease, for example, or different. These studies use different doses of ivermectin. Some of them are compared to an active arm. For example, what we discovered when we did our sensitivity analysis, which is it's an analysis to check if there are reasons for heterogeneity, for the inconsistency, for example. So we removed this study, Fonseca, and when we removed that study, we found that this number disappeared. Sorry, I think I've just switched slides. We found that the heterogeneity disappeared when we removed this study. Now, this study was done amongst very ill patients, and they didn't find much of a difference between ivermectin and the control arm, but the control arm received hydroxychloroquine. So basically, there was a comparison between two fairly active treatments. I know that, there is a current perception that from WHO and so on, that hydroxychloroquine doesn't work, but that's not necessarily true. And there are many reasons to believe that it is active. So in actual fact, here this study did compare ivermectin with something that's an active treatment, and so one would expect perhaps that they wouldn't have picked up much of a difference between the two. In any event, once we've established we know the reason for the inconsistency, we can put the study back in and say, okay, well, this is the situation. We have a bunch of studies that aren't exactly the same, but we don't need to worry, because we know that in actual fact, what including the Fonseca study would actually underestimate the effect, not overestimate it. What it would do is suggest that there isn't a difference, when in actual fact, the overall result shows that there is. So we're not worried about making, it's not, it's not overestimating the effect. It's not saying that there is an effect when there isn't one. So
the 68% really is the minimum effect that these studies would indicate is.
Yes, the minimum average. It does appear to be that. So, we carried on looking at trials, and we found by the 31st of March, we found 3 new studies, new randomized controlled trials, and 2 of them had data on deaths. So we included these data. So the one is Lopez Medina, and it was conducted in mild disease. There was only 1 death in the control arm and none in the ivermectin arm. And the other study is Gonzalez. And in this study, this was also severely sick patients. There were 5 deaths in the ivermectin arm and 6 in the control arm. And when we look at our overall summary now, we have 62% reduction in deaths, and with a confidence interval of 27% to 81%. So we're still in, it's just saying the same thing.
So the minimum from this data that the ivermectin reduces deaths is 27%, and it may be as high as 81%. I mean,
Yes, and it's really it's going to keep on fluctuating, because really, the more studies you do, and depending on the patient group you're looking at, it's going to change. So, one's just rearranging the deck chairs on the Titanic. Really, there's no, we know it works, and this estimate will keep on changing, depending on which studies we look at, what dose they're using, who their patients are, and so on.
And this methodology, this meta-analysis test, this is sort of tried and trusted research methodology, is it?
Yes, yeah. And this is the software that we use for doing Cochrane reviews. So it's standard software, it's standard methodology. If this had been a Cochrane review, then this is the analysis we would have done. In fact, we do have a Cochrane review, and it just isn't published. So the plan is to publish the full Cochrane review, even if it's on a preprint website, in the next couple of weeks or few.
Oh, right. Something to look forward to.
Let me say in the next 4 weeks, so that I don't, give myself enough time. But
I know you've been pretty busy lately.
It's quite a hefty document, and it was prepared for submission to Cochrane, and then and the thing is, what you need to remember is with Cochrane reviews, there's a protocol that goes with it. So many reviews are done, and you're not quite sure why they grouped their studies the way they did, or whereas our review has a protocol which is basically a recipe for how you're going to do it. And we've got that protocol, and we've done it according to the protocol, and so there's no surprises, and it's not it's not as if we sort of grouped the studies differently or done anything different with them. We said how we would do it, and this is the product of that recipe.
So basically, since we've talked last time, what's happened? I mean, what's the story with the World Health Organization and the ivermectin, their current recommendations or views or dictates or whatever you want to call it?
Well, okay.
Do you want to do this first? Sorry.
Well, it's fine. We can go on with this.
Yeah, let's do this first. Sorry.
So the World Health Organization has revealed their recommendation on ivermectin, and it's not in favor of ivermectin. It's against ivermectin. They base their decision on this on a systematic review done by a group at McMaster's University. And the only forest plot in the guideline recommendation that I can comment on is this one here, because this is the only one in the guideline.
So the World Health Organization recommendation is made on these few studies, whereas you had, how many was it, 21 studies?
We've got 24 in ours now, and in 24. The GETS analysis, we've got 15.
Right.
But they seem to only have found 5 in this meta-analysis, but I'll show you later on, they seem to have refer to 7. But in this analysis, which is of deaths, they have 5 studies, and they've grouped them, you can see, according to high risk of bias and low risk of bias.
Yes.
Now, I have not seen a protocol for this review, and I have not. I'm surprised that they have grouped them that way in terms of high risk of bias and low risk of bias. I've never seen that done before necessarily. Usually we do that in a sensitivity analysis. For example, I'll just go back here. This is our sensitivity analysis. And what we did is we've just removed the studies that we assessed as being of high risk of bias to check whether our findings are the same. So we've removed 4 studies from this analysis, and we found actually when we remove the high risk of bias studies, we have a 72% reduction in deaths and a confidence interval of 15% to 91%. So it's quite a broad confidence interval, but it's still in favor of ivermectin. It's consistent with the overall thing. So we'll just put those studies back in and not worry about them too much. And but that's not what's happened here. Here they've separated them into high risk and low risk. I have concerns about this group anyway, because Gonzalez and Lopez are both high risk of studies in our analysis. And I recently had the Lopez Medina study evaluated by some job applicants who were applying for a systematic review job, and they all came up with this being high risk of bias. So it's not just our group who finds the study to be a high risk of bias. It seems to be regarded quite widely as being of high risk.
And yet this is what the World Health Organization are basing their thinking on.
Yes. And Gonzalez was also high risk because there's no clear description of how they randomized patients. And it seems like they've randomized them and then on different clinical criteria. So we have queries about the study that need to be answered. So both of these in our review would be classed as high risk of bias. And so the overall, they don't have a lot of data here. They've only got 31 deaths in all. It still clearly favors ivermectin. But I have lots of questions about this, which I hope to get answered. I've emailed the authors of the systematic review, and I will be emailing WHO as well. The 4 studies here, Hashim, Alcazar, Okamus, and Mahmoud trials, these were in Andrew Hill's original analysis, so they were good enough in the original analysis that WHO and UNITAID did, but somehow they're not in this analysis. There are only 5 in this analysis, which is very strange. There were 6 in the original analysis. So, and the other thing is they've used fixed effects. Now, this is a fixed effect model. This is surprising because this usually assumes that the trials are all very similar and the data are consistent, whereas that's not the case in this analysis. The data aren't consistent. There's a fair amount of inconsistency, although they haven't actually reported their I-squared. And also
which is the heterogeneity of the studies.
Yes, and also we know that these studies are all quite different. Some of them are in low risk patients, some of them are in high risk patients. They give different doses of treatment. So it's surprising that they didn't use random effects. We certainly pre-specified in our protocol that we would use random effects because we were expecting quite a lot of heterogeneity or inconsistencies within the trial designs and patients. So, well, anyway, you can see they still get a 72% reduction in deaths with a confidence interval of 25% to 83%.
So even assuming that this is a good methodology, which I think we've established isn't particularly good, it's still showing a 72% reduction in deaths, and they're still recommending against it. Can you help me out here?
Well, I just want to, there's a little personal bugbear here is, it seems very slapdash. They haven't even bothered to remove the brackets from the titling here and so on. So, yes. Carry on. So then in terms of their summary of findings, now this also conflicts with what they present in the figure. And as I say, it could just be a factor in that they haven't provided all their workings. So somewhere in the background, there must be a full set of forest plots, but it's not available in the guideline document, and the systematic review on which it's based doesn't seem to be published at the moment. So we just don't know where these data are coming from. What is very peculiar here is that whilst in the previous figure, in the previous forest plot, they report risk ratios, here it seems like they've done a completely different analysis and they're reporting odds ratios. Now,
that's a different thing, Tess, isn't it?
It's a different thing. It's a different calculation. So, and then they get 0.19, which is even more effective. So it's 81% reduction in deaths. And the confidence interval is 0.09 to 0.36, which suggests a confidence interval of 64% to 91%. So it's a very tight confidence interval.
Yes.
And this is based on data from 1,419 patients in 7 studies. So in the figure, we've shown 5 studies. Here they refer to 7 studies.
It just doesn't make any sense, does it?
It just doesn't make any sense.
And this is the World Health Organization. This is the World Health Organization we're talking about.
Yes. And then in their absolute effects, we've got standard of care. So if you don't get ivermectin, you just get
standard care. Yeah.
A standard of care, which is basically nothing. At the moment, you get.
Well, it would be the oxygen and the dexamethasone.
Yes. Yeah. Sorry, I just mean generally we don't have any specific treatment.
No specific antivirals. Yes.
You have a risk of death across these studies in their data of 70 per 1,000. And if you get ivermectin, you have a risk of death of 14 per 1,000. So the risk difference is 56 fewer deaths per 1,000, according to their analysis, which shows, and then the confidence interval is it's 44 fewer to 63 fewer. So it might be as many as 63 fewer deaths per 1,000 if you were to get ivermectin, according to their analysis. Nevertheless.
so they've basically done this, we believe, highly flawed meta-analysis. This meta-analysis has shown high levels of efficacy for ivermectin, and they've recommended against ivermectin. I mean, am I missing something here?
Well, it comes down to their grading. So what they say in their grading is that even though they have an odds ratio of 0.19 showing an 81% risk of death, 81% reduction in death, and that narrow confidence interval of 64 to 91%, they say they've graded the evidence as very low due to serious risk of bias and very serious imprecision. Now, we just looked at that risk ratio or odds ratio, confidence interval, and it was notable for its precision, actually. 64% to 91% is a very precise estimate, much more precise than our original one based on all those studies because of, there's just a mismatch. They've got a precise estimate, which they're downgrading twice for being imprecise, and then they're interpreting it to say the effect of ivermectin on mortality is uncertain. So, and in actual fact, this is very uncertain. They use the word very uncertain in their documentation, but it's missing from this interpretation. So So there's just something very strange going on here. Their grading needs to be checked. And
is this open to peer review? Is this open to a peer-reviewed process?
It doesn't seem like it. No. It seems
I mean, to do a peer-reviewed process, you would need full data.
Yes.
And that just doesn't seem to be available. It's at least not in the public domain.
It's not in the public domain, and there's no evidence at the moment which studies, what 7 studies these are. I tried to add and subtract the studies to see if we could get 1,419, and I just ran out of time and patience. It really needs to be transparent. We need to know what studies, what data they've included, and in actual fact, why, with such a great, precise estimate, is this, and due to serious risk, so serious risk of bias leads to downgrading of 1, because when you're grading data, evidence from randomized controlled trials, you start off with a presumption that it's high quality evidence or high certainty evidence, and then you downgrade it for various criteria. So for risk of bias, for serious risk of bias, you downgrade by 1. For very serious risk of bias, you downgrade by 2. For imprecision, you downgrade by 1. For very serious imprecision, you downgrade by 2. So you can see here, they've downgraded for serious risk of bias, which is -1, which would take you to moderate certainty. And then they've downgraded for very serious imprecision by 2, which takes you down low to very low. So they've got very low certainty evidence, when in actual fact, even if they decided, well, they would prefer to have more events to be sure, and decide to downgrade once for imprecision, they'd end up with low certainty evidence, which means that ivermectin may reduce the risk of deaths substantially. For example, just like this one here, do you see here, they've got low certainty evidence. This is the data for serious adverse events. They've got low certainty evidence, and they've interpreted that ivermectin may increase the risk of serious adverse events. Now, this is a bit of an anomaly as well, because if you look here, they've downgraded twice due to very serious imprecision. So the same as for the mortality. But in this instance, there is very serious imprecision. You can see here, the confidence interval spans from favoring ivermectin to favoring the control group, and it crosses that line of 1. You can see the number 1 would fit in the middle here.
Yeah.
So in actual fact, there is no clear difference. From these data and from this estimate, you cannot say whether ivermectin causes more serious adverse events, or whether the control group whether the control medicine caused more serious adverse events. So in actual fact, this is another misinterpretation of the data. What this should say is ivermectin may make little or no difference to the risk of serious adverse events.
It's not as if it's a new drug, it's a well-known drug.
Yes, and nobody knows that better than the WHO, because they stress that over and over in their guidelines on ivermectin for neglected parasitic diseases and SAEs.
Well, the explanation you've just given, Tess, I could follow that. I could see that you were pointing out that you as an expert in this. I could see the anomalies you were pointing out, and the anomalies that were fairly glaring to me there. And there's a lot of questions that need to be answered.
So I just want to say this is the document.
Right.
And you can see it was updated on the 31st of March.
Mm-hmm.
In the document, they say WHO recommends against ivermectin for COVID-19, except in the context of a clinical trial. And here, where they talk about certainty of evidence, it's as I was describing, that evidence was rated as very low certainty, primarily because of very serious imprecision for most outcomes. Now, this is simply not true for deaths. And it says the aggregate data had wide confidence intervals and or very few events. Well, for deaths, it certainly did not.
Right. And yet this is what governments around the world are now following.
Yes. And then I just wanted to show you, so The WHO follows, they have this handbook for guideline development, which is what I'm used to using in the documents that I prepare. And they have something on imprecision. They have a description of imprecision, just so that you're aware that this is actually, documented. There is a method to this. So it says 4 guideline development groups. If the confidence interval for the pooled estimate of effect crosses the threshold established for making one decision versus another, i.e. in favor of one or the other, then the body of evidence is imprecise for the particular outcome in question. And the quality of the evidence is lower than it would be otherwise, owing to the uncertainty in the result. So as I showed you, that effect estimate lies clearly to the left of the line in favor of ivermectin. There's no imprecision.